Welcome, everyone. My name is Miles Griffis. I'm the executive editor of the Sick Times. We're so glad to have you here tonight.
Yeah, so I assume most folks who are here, know the Sick Times, but just like a little bit of background. We are a nonprofit news site that focuses on covering long COVID. We publish both news stories and essays and op-eds, which are called commentary pieces. So we cover research, we cover healthcare issues, policy issues, arts, and more, all kind of pertaining to long COVID community. And it's very important to us to acknowledge that the pandemic is still going on, that people are still getting COVID and long COVID, and that this is really a continued crisis. And we really try to not minimize people's concerns within the community or uh, deny everything that's happening. And so part of that, that is very important to kind of maintaining or emphasizing the continued nature of COVID spread is weekly COVID-19 trends updates that I write. I don't think I introduced myself yet. I'm Betsy. I'm the managing editor and one of the co-founders of the Sick Times. But before we started the Sick Times, I actually wrote a separate newsletter about COVID-19 data. And I also previously was a freelance journalist before starting the Sick Times, and COVID data was my main beat, as we journalists call it. So it's kind of my main focus area for a couple of years. So I wrote for publications ranging from like 538 to Stat News to local publications in New York City, where I'm based. And so I really developed a lot of expertise on following different data sources. And I try to bring that to the updates that I still write on a weekly basis. So I wanted to share a little bit just before we kind of get started with discussion on what goes into those weekly COVID-19 data updates and the sources that I use to write them. So the image that you'll see here is from the update we just posted today and that went out in our newsletter a few hours ago. It's kind of good news, as you can see with the yellow colors here. COVID-19 levels appear to be on the lower end in the US. I say appear to be because there are a lot of uncertainties and caveats in the data these days. But kind of compared to the information that we have with the historical data, levels seem to be lower. So in terms of the sources that I use, one of the big ones really is wastewater surveillance, and there are three main dashboards that I look at. One is the CDC, so that's on the left here, their National Wastewater Surveillance System. And this is really a massive data collection endeavor that compiles information from wastewater testing sites around the country. Many of those are run by state and local public health departments that then kind of report up to the CDC. And then the second one is called Wastewater Scan. So that's the middle image here. And they are an academic organization that started testing for SARS-CoV-2 in sewage early in the pandemic in California and then kind of expanded around the country. So they have a bunch of testing sites across the US. And because all of their testing goes through one organization, it's all done with the same methods and analysis. And so that helps to have a bit more of a standardized data set. It's a bit easier to compare and contrast across sites. And they also have longevity of their data, particularly for some of the California sites where testing has been going on since early in 2020. And then the last one, which is the chart on the right here, is BioBot Analytics, which is a startup that's also been doing COVID-19 wastewater surveillance since early in the pandemic. And both Wastewater Scan and BioBot also now do surveillance for some other viruses and other pathogens, which we might talk about more later. And then other sources that I look at are healthcare system data from the CDC. So on the left here is a screenshot from test positivity data that the CDC provides. This is from a surveillance system that's basically laboratories that are doing PCR testing across the US, and they report up to the CDC on not just COVID, which is the red line on this chart, but some other respiratory, like so-called respiratory viruses that spread through the air. And then the enteric dashboard here is mostly norovirus data, I think. And then on the right is a screenshot from a CDC page called the Center for Forecasting and Outbreak Analytics. And so this is a center that does estimates whether COVID-19 cases are going up or down in every state, as well as also flu and RSV cases based on emergency department data. And then another thing that I often look at is wastewater data, as well as other sometimes other metrics from state and local dashboards, from state and local public health departments. So I put screenshots here of one from New York State on the left and one from California on the right. These are both states that have more comprehensive pages where they're posting their own like wastewater surveillance data. And it can be helpful to look at these because sometimes they're updated more frequently or they have more recent data than what you find on like the CDC. And sometimes also their categories are maybe more comprehensive or you can find more information, even though the data that are here generally are also like reported up to the CDC and are on the CDC's dashboard. And so if you're looking for data in your area, you can check out you could look for a dashboard like this run by your state or run by your county or your city. And hopefully my colleagues will put a couple links in the chat to like there's a list that I maintain of a bunch of these. There's also a dashboard run by a research team at the University of Merced called COVID Poops, which is also a great place to find wastewater data in different places. And then, of course, I also look at variants. So these are a couple of screenshots from two CDC dashboards that estimate prevalence of different variants in the US. The one on the left is based on sequencing from testing, like PCR tests. But as there's, of course, much less PCR testing going on these days than there used to be, that these estimates, have to be taken with a grain of salt. And you can also look at wastewater surveillance, which is on the right. So this is estimates of variants based on how they're showing up in sewage. Okay, Melanie is putting a bunch of links in the chat. Thank you, Melanie. And then, of course, there are other people who do regular updates on COVID data. I just put a couple of the ones that I look at here. So Force of Infection is the newsletter written by one of our guests, Caitlin Rivers, and her colleagues. There's also the Your Local Epidemiologist newsletter, another one called the Dr. Ruth Report. And then, as many folks might know, you could often find on social media or in different places estimates of case counts in the US that are kind of translated from wastewater levels. There's a lot of complexity that goes into interpreting wastewater data that I think we'll talk about more later. So personally, I choose to not cite these directly, but sometimes I will also look at them and I put them on here because I know they're common sources. So that's it from my kind of short intro. Hopefully I didn't go too fast, but obviously happy to answer more questions about all of this stuff later. And I'm going to stop sharing my screen just for now, so that we can go into more discussion with our guests. Awesome. Okay. So, Caitlin, let's maybe start with you. Could you just introduce yourself a little bit, talk about your work, what you would like folks here to know?
Sure. My name is Caitlin Rivers. I'm an epidemiology professor at Johns Hopkins, where I run the Center for Outbreak Response Innovation, or CORI. But many of you may know me through Force of Infection, which is a newsletter I've been writing for 4 years now. And I write weekly along with my fellow colleagues on COVID-19, flu, RSV, norovirus, food recalls, and then other relevant news. We publish 52 weeks a year and have been consistent for, like I said, 4 years now. So I've spent a lot of time looking at this data and looking forward to the discussion today.
And then T, would you also introduce yourself, please?
Yeah, of course. Hi, everybody. My name is T. I use he, they pronouns. I'm a disabled nurse of 6 years with experience in abortion care, emergency medicine, hospice, and home care / like case management. I literally graduated from at the start of COVID from nursing school, but I've worked in healthcare for the last 12 years in one capacity or another. I'm a first aid instructor with Readiness Collective of New York City, ARC-NYC, formerly known as the People's Health Education Program. With ARC-NYC, I co-teach a mass-required politicized first aid class run on a monthly basis, which has been ongoing since more or less 2022. I'm also the lead medic of the Community Health Initiative, which is a free mass-required clinic run by ARC-NYC, and For Liberation, which is a Black communist organization based in Brooklyn. I make zines on health and communism, and I just recently republished a zine earlier this year titled On Communism and Medical Care. I am, disclaimer, by no means an expert in infectious disease, just some guy who's been in healthcare since he was 16 and has been further disabled by COVID. But yeah, very excited to be here. Thank you.
Thank you.
Thank you all so much for introducing yourselves. I guess, yeah, so Betsy sort of gave some of the sources that she looks at as she writes trends. Caitlin, I'll start with you. What are some of the main ones you and your colleagues look at when you write force of infection?
My favorite source is actually ED data, so the percentage of visits to the emergency department that are for any of the three major pathogens. I like this because it is collected all across the country, so there's a very good catchment area. The metric is the same for all jurisdictions, and it is reported year-round. I do look at all three major pathogens, COVID, flu, and RSV. And I would suggest if you have listeners have capacity to take a peek at the other pathogens as well, because like COVID-19, flu and RSV can be really hard on people who have underlying health conditions. And they can also cause long-term health conditions from people who were previously healthy or otherwise recovered. So I think it's good to keep an eye on all three. But NSSP data is how you might see this ED metric referred to. That's National Syndromic Surveillance Program. And again, it is the percentage of visits to the emergency department that are for the pathogens.
Thanks for that. And T, what are some of the sources that you have found helpful?
The sick times. I also like looking at wastewater scan accounts on Instagram like Michael Holger, Sam HEDS. Yeah. But I think it's really cool that Caitlin, you look at like the ED data. I think that's a really smart way to think about it and look at it.
Yeah, many people are hesitant, I guess, to use ED data because it's further along in the course of illness. Only a small fraction of people who become infected will require emergency department care. So I recommend not looking at it as an absolute measure of activity, but like wastewater scan or wastewater data, it's a measure of trends and like relative intensity. So even recognizing that it only represents a small fraction of people who are infected, it still does a really good job capturing where we are in the season and how things are changing. And so I think that's important. And again, I do this for a living. This is a business for me. And so I'm not suggesting everyone needs to like embark on this, but I like to look at a constellation of measures and kind of triangulate them. That's the value I provide to my readers. And so the NSSP data is just one I brought up since Betsy didn't feature it, but test positivity can be part of the picture. That's really good early in trends when things are changing before the other measures really catch up. Wastewater data, and then influenza has its own kind of set of measures. But the more kind of angles that you can look at it from, the more insights you can get into what's happening.
Yeah, no, I definitely do that too in terms of looking at the different sources. And I think I briefly mentioned the CDC Center for Forecasting and Outbreak Analytics, CFA, but the maps that they post are also based on emergency department data. So it's like kind of another interpretation of what Caitlin was talking about.
Very cool.
Yeah, just if Miles, is it okay if there's a comment in the question that
course,
directly relates. So some commentators, and I've heard this before as well, are noting like, well, I wouldn't go to the ED even if I felt like I needed care because it's not a safe place for me, or other people in my community feel the same way. As long as those sentiments or the the ways that people are seeking care and the proportion of people who are ready to seek care is relatively stable over time, it's still a valid metric from an epidemiological perspective. That is not commenting on the appropriate, like that is a good place for us to be as a country. But as long as that is consistent over time, then the trends are still going to be reflective of what is happening. And so even though it's very true that not everyone has access for financial reasons or for reasons of safety or whatever, as long as that it can be accounted for similarly over time and there's no major, like a natural disaster that's really going to change the way that people are seeking care, then we can still rely upon it for epidemiological purposes.
That makes sense. Yeah, the next question I wanted to ask, we've gotten it a lot when people registered for this event. We've seen it in our social comments, and I just saw sort of a similar comment here. We get a lot of readers asking us if CDC data are still trustworthy, both because of the widespread defunding and dismantling of health agencies under Trump, and because of how the agency has underplayed COVID-19's risk across the last few years. How do you all view CDC data and guidelines in 2026, and what caveats might people consider when they interpret information from the CDC?
Yeah, I'll just start with one when it comes to wastewater data. I kind of mentioned this briefly earlier, but when you look at the CDC's National Wastewater Surveillance System page, that system is essentially bringing in data from a bunch of different health departments, a bunch of different places that are doing wastewater testing. And different places do that testing in slightly different ways. They might have slightly different frequencies. They might have, different dynamics of like chemicals in the water, animals in their areas, weather, and all of these kind of different factors impact the levels of not just COVID or SARS-CoV-2, but other pathogens that might be in that sewage, right? Like sewage is by definition very, very messy. And so the CDC is trying to standardize from all of these different places and from all of these different public health departments. And so often I notice as I'm writing updates from week to week that sometimes the CDC data will kind of go like this, like this has been happening in the South recently. If you look at like the regional metrics there, where it'll appear to be going up one week and then sort of down a lot the next week. And I think that's because there's this kind of standardization attempting to happen from all of these different places. And sometimes it's a little messy. And so sometimes you kind of see like trends will even out more over time. But from week to week, it can be a little challenging. And another thing that the CDC kind of does to try and standardize is they have this new metric they've developed called wastewater viral activity levels, which is meant to refer to the level of SARS-CoV-2 in sewage. And so when the CDC kind of standardizes, it's taking each site in its network compared to historical data from that site. They've decided to kind of reevaluate these historical averages. I think it's currently twice a year. And so there's also kind of an adjustment that's happening. And those adjustments are generally based on more recent data. So it's a little bit more challenging just from this one source to look back at the periods back in 2021 or 2022 when we had more widespread masking and other kind of more widespread public health measures. And so it's a little bit more challenging to do that kind of directive comparison that I think many of us often want to do of saying like, okay, right now maybe levels are on the lower side, but how is that compared to this like earlier period a couple of years ago? Just the way that the CDC operates, they're doing something very difficult with like trying to standardize this very messy data. But it's also like can be a little rough to look at from week to week. So that's my kind of big example. So it's not like I'm saying like there's still a lot of value in looking at it, but you kind of have to take it with a grain of salt and be very careful, especially if you're like writing weekly updates like I am.
And in terms of considerations about political interference, I've kept my eye on this to kind of evaluate whether I see any discrepancies or changes to the data that make me doubt its validity. And I have not seen that with the exception of the shutdowns. During the shutdowns, no data were published, and so that was massively disruptive. But there is a lot of redundancy in the system. The values that CDC are reporting on their website are collected from all 56 public health jurisdictions. And those jurisdictions are publishing their own data on their own websites. And so you as an individual can cross-check that what the CDC is reporting is the same as what the state is reporting. And the state also would be able to say like, hey, that's not what I told you. And so I think for respiratory viruses specifically, there is enough like different ways to triangulate and double check that I can confirm and say with confidence that I have not seen evidence that the data are not reliable from that perspective.
Yeah, and I'd say that, like, historically thinking about the CDC, I would just take a big grain of salt with whatever they say. Like, I remember when I went in urgent care because I had a flu infection a couple of years ago. The provider at this urgent care, the doctor, he said that the CDC guidelines don't say that you can return to work after 1 day testing positive or something like that. And that, yeah, so I take it with a big grain of salt in terms of like their specific guidelines on how to mitigate COVID infections and respiratory viruses in general.
Great. So now I'd want to ask, we get a lot of questions about local data. People email us and say, how can I find a very specific wastewater in my area? What are these top sources that people should be looking at? I know we've talked about them a little bit. And then if they don't have a local wastewater reporting, what sort of data is available to them that can help them get a better sense of respiratory virus or other virus spread in their communities?
I have a couple ideas I can share. Betsy probably has more, but the CDC's respiratory illness dashboard, I think that's the title of the site, has a drop-down menu that allows you to click your county. And it will, once you do that, it will pull up the metrics for all 3 major pathogens. And it's all the metrics. Like you can look at wastewater, you can look at test positivity, you can look at what the Center for Forecasting is saying. So that is one option. Or you can Google for the health department in your jurisdiction, and whether it's this county or the state is going to depend on where you live. So that might take a little bit of sleuthing. But almost every jurisdiction has their own respiratory illness dashboard now that you can review and access data on.
Yeah, I think I shared earlier, but there's like a spreadsheet that I put together a couple of years ago and try to regularly check and update with some wastewater dashboards that are run by individual states and in a few cases, more local jurisdictions. So those are some good options. You can check if one of those is in your area. Another thing that I have heard from epidemiologists like Caitlin is that even if there's not testing happening in your specific county or your specific city, it can still be helpful to look at nearby areas, or even at your state, as a whole. Like if you say you live in like Long Island, certainly what's going on in New York City would be relevant to you because that's a major metro area that's nearby. And if there's a ton of cases there of COVID or flu or whatever else, they would likely also be reaching into your region. People would be commuting in and out and potentially bringing infections and things of that nature. Or if there's, like a town that's having an outbreak near you and you're in more rural area, I think some of the same kind of dynamics apply. Like these are not viruses that are contained to one region at a time. They really spread around a lot. Such as why we're still seeing a lot of COVID cases. One of many reasons why we're still seeing a lot of COVID cases 6 years into this. So I think it's obviously helpful to find data that are as local to you as possible, but things that are at the state level or the regional level can still be really helpful, is kind of advice that I have learned from different interviews I've done on this subject.
And what about more sort of international sources? Are there, recommended sources? I guess, yeah, they're newsletters, epidemiologists who are compiling stuff in other countries that are useful um, for people who are looking for that in other countries. We have a lot of international readers.
The UK and Canada has great dashboards that I'm very familiar with. And they can often provide insights into like what we can expect if we hear of an international trend that hasn't reached the United States yet. Often the UK will have early reporting that helps me to anticipate what we'll face in the weeks ahead. So I think that's a great resource, and they do really awesome work. I'm not familiar personally with a lot of dashboards beyond that, but I do know that if you are not in a country with a highly developed public health system and a highly developed reporting system, it's going to be really hard to find high quality information. And so I would just account for that. For example, the World Health Organization does report on COVID-19 in all of the different WHO regions, but you'll notice when you look at the data, it doesn't make any sense. Like there are like huge areas of the globe where almost no cases are reported, and that's obviously an issue with the reporting itself and not with the disease.
I get your newsletter.
Cool.
Caitlin Rivers.
Hello, probably you should mute, but thank you.
That's great. Yeah, so I think one question that a lot of readers have also had that we got from participants, we've seen COVID-19, surge multiple times in a year, usually around two. Is this a trend that we are going to see in perpetuity? Like, is this something that, the trends and all we've seen over the past 6 years, will continue going forward? And what would it take to get it to stop?
Yeah, you should go first.
I think my 2 cents is that COVID will likely continue until there is something big that completely overthrows the current system and establishes a new system that is not only more efficient, but also like more, I'm just calling for a revolution is what I'm saying. Is that like only in a revolution, I think that only under perhaps socialized medicine and under a socialist society can we perhaps see trends going down. Because I think under capitalism, they have incentive to continue the mass deaths and disablement, because when you're sick and disabled, they can still profit off your bodies through the healthcare system, through the nursing home system, and all that. But yeah, go ahead, Caitlin.
I can maybe talk a little bit about the seasonal pattern. We are seeing twice yearly surges, one in late summer, one in the winter. This is unusual for respiratory pathogens. The other ones are more late fall into winter. We don't really have any summer respiratory pathogens. So that one is a surprise to me, even as an epidemiologist. It has been enough years that I feel like it's going to stay like that. But my silly little slogan is not the right term at all, but the saying is never trust flu. And I feel that way, that's broadly true of all respiratory pathogens. Never trust COVID, never trust flu, never trust RSV. I don't know what's going to happen in the future, but because we have settled into this twice annual summer bigger than winter pattern, that's my expectation going forward. And there's no epidemiological reason why I would expect that to change.
Yeah, that all makes sense. I also think that the variant piece is very important with this. I think I know at least a lot of experts who I was talking to at the time were kind of surprised to see how fast the SARS-CoV-2 virus evolved back in like 2021 when we started to see variants. And it was a kind of a big downer when, like everybody got vaccinated and we thought we would just have herd immunity and it would be fine. And then suddenly like Delta came on the scene and we had like big waves again. And then Omicron also had, led to tons of infections at once when it first arrived. And so I think that kind of adds also to the unpredictability. And the same goes for flu too. Like we're always watching out for bird flu continuing to jump to new species and things like that. So yeah, hard to predict, but I think all of the surveillance that's going on, looking at this kind of genomic evolution is helpful.
That's super helpful. Let's see. Yeah, so Betsy talked a little bit about this earlier, but I'm curious to hear from the panel sort of, we see some some data on COVID-19 that sort of translates wastewater into like the amount of infection that is happening potentially in a community. How do you view these translations? And yeah, I guess sort of expand sort of more on them and how they might work if they do.
Yeah, I mean, I could start. So I speak from this, obviously, from the journalist point of view, not as someone who actually is going out there doing the wastewater data collection and analysis. But having interviewed a lot of those folks, I feel I have a decent understanding of the massive amount of complexity in sewage. Like I was saying earlier, it's not just human waste. Sometimes there's animal waste in there. Sometimes there's like runoff from weather, chemicals. I've heard of examples of places doing wastewater testing in like more agricultural areas where they have to kind of understand and triangulate interference from like chemicals that are being put onto fields, things like that. So it's just very complicated, and it's also kind of very individual, like by location. And so kind of as a result, there's a lot of science I think that still needs to happen to better understand what exactly is the relationship between the levels of a virus in a wastewater sample and the levels of actual infections in the community. There definitely have been a lot of scientific papers looking at this question and that have found like a strong correlation with COVID specifically between the wastewater estimates and the cases in the community. However, a lot of those studies were done, earlier in the pandemic. They're like a couple of years old at this point, and the virus has continued evolving. We keep having new variants, and so there's kind of a question, less a suspicion and more of a question from some experts of like, has the evolution of the virus changed how the virus shows up in wastewater? Like, does an individual person who's sick maybe have more or less viral shedding now than they might have a couple of years ago? We don't really have a good understanding of that, in part because there's less PCR testing and all of this stuff. So that's kind of a challenge, and things can vary by person to person and location to location. And so as a result, I think it's just very hard to get a direct estimate. And so that's part of why I don't cite them personally. I do think it's still helpful because I can understand, as a science communicator, we want to be able to put things into terms that we can easily understand. And a level of a virus in a sewage sample is like kind of hard to wrap your head around, whereas a level of cases in the community is relatively easier to, say, share with a family member who you're trying to get to like wear a mask at an upcoming gathering or on their next flight or something. So I do kind of see why these are very popular. And I think it can be kind of helpful to say like, okay, broad strokes, there's a lot of case, like we think this is maybe a general magnitude of cases. But yeah, personally, I don't like cite them in my numbers. Caitlin, I'm curious what you also would think about this.
Yeah, I agree. There's a lot of assumptions that would go into those numbers. I agree with all of the ones Betsy laid out, and a few additional ones may be the relationship between well, I guess you did say this, but the relationship between wastewater concentration and our next available metric, which is ED visits, if you're thinking about the pyramid of people who are infected. And that relationship between, say, the people who are sick at home, the people who go to the outpatient doctor, the people who go to the ED, the funnel or the way that people progress through their illness, that changes over time. So there's just a lot of assumptions across every corner of the dynamics here that I think make it really hard to say with any confidence that you've got it down.
All right. I think Betsy talked a little bit about the sort of lower COVID trends we're seeing right now in the US. When current metrics from wastewater surveillance, sorry, excuse me. When current metrics from wastewater surveillance and other healthcare systems are compared to the last couple of years' datas, how do we sort of interpret these low levels, I guess, compared to earlier in the pandemic? What kind of lows are we seeing? Are they true lows? how can we help readers kind of make sense of this point of data in the pandemic?
Yeah, so this is fresh in my memory because I was just writing about it for today's COVID trends updates in our newsletter earlier. But I like to look at wastewater scan, also BioBot analytics data to kind of look at the national wastewater estimates because these sources have a bit more longevity in terms of they've been testing at a bunch of sites in the same way, mostly in the same way for like the majority of the pandemic at this point. Whereas with the CDC, it's a bit more complicated, as I was saying earlier. And so with both of these data sources, current levels are the lowest we've seen since like spring 2022, right after the first big Omicron wave. And they're kind of approaching the lows that we saw in 2021, like right after everybody had gotten vaccinated and there was a lot of immunity from the vaccinations. And also test positivity, which I like to look at, is the lowest I've seen it in a couple of years. If you look at the national estimates from that CDC surveillance program that I mentioned earlier. Um, and so that's pretty good, but of course with a caveat about the wastewater data from what I was just saying, that we don't necessarily have a good understanding of how variants might have shifted the way that viral load is showing up in those samples.
Yeah, nothing really to add. Just a quick look ahead. When we normally see the summer surge starts, I often see the first inklings of change in July, and then August and September is when things really start to pick up. So that's the typical seasonal calendar. Obviously, I check week to week to see whether that's holding up, but that's roughly what you can expect.
Yeah, I'd say this current lull feels like a calm before the storm.
Yeah, that is often what happens.
Yeah, so with, something Betsy's been keeping track of in our updates is a lot of people have been talking about the cicada variant. Um, I'm wondering if there are it seems like from today's update from Betsy, at least it's still not causing significant cases in the US, but is a looming threat. What do we know about cicada so far? And I think there's also been sort of some misunderstanding in the media. It seems like a lot of people are talking about it as this brand new variant, but it's been around for longer than that. So I'm curious of just sort of any updates we have on cicada right now.
I have a write
Yeah.
up on
Oh,
this. Oh, sorry, Betsy. I was
no,
looking
go
at
ahead.
my
Go
chat
ahead.
to put the thing in. I have a write up on this that I can share. The long and the short of it is that it's a highly mutated variant, so that's why it caught a lot of attention because it's very different from the previously circulating variants, but it doesn't seem to cause more severe illness. And there's some uncertainty about whether it's more transmissible or evades immunity, which would cause it to really like take root. But I haven't really seen a lot of evidence that that's playing out, which is it's very hard to look at the genomic epidemiology and say what it's going to do in the community. So it's very normal to say, oh, I don't really know. But that's kind of where we're at. It looks okay for now, but keep your fingers crossed. Betsy, is that how you're interpreting?
Yeah, I was also gonna say like it's a little hard to tell just because like there's less testing going on in terms of PCR testing than there was, in the couple years ago, 4 or 5 years ago. And so that makes it a bit challenging to know like exactly where this variant is right now. The CDC has two kind of main variant estimates pages, one that's based on PCR testing, where people's samples then get sequenced to find out what variants are going around. And then the other is sequencing from wastewater samples. And both of those are currently only updated once a month. So that is a little challenging if you're trying to keep track of a variant of concern on a more regular basis. I do try to look out for, there are a lot of folks on social media who closely follow samples that are posted to GISAID, which is an international repository of sequencing data for SARS-CoV-2. And they often will try to follow, like, okay, here's this variant is growing in this place, and this one's maybe growing in that place. And so those samples do seem to show that this variant cicada, as people are calling it, is kind of increasing in prevalence. But those the level of testing that is leading to those samples is much less comprehensive than it used to be. So it's kind of tricky to draw major conclusions at this point.
That makes sense. T, I wanted to ask you sort of a follow-up question about sort of this lull that we're having. What recommendations do you have for readers, listeners who are interested in advocating for more COVID-19 safety measures in their communities or organizing spaces? Specifically, one person who registered asked about advocating for keeping safety measures at events when the local risk levels may be lower, as we're seeing right now. How do you sort of keep that in people's minds, even though, there's still a threat out there, even though it's lower?
Yeah, I'd say that even when local risk levels may be lower, there's still good reason to mask up at any event in this day and age, both indoors and outdoors, because there's airborne pollution. There's also operational security. Those are two big reasons why I personally still mask, in addition to the ongoing pandemic. ARC-NYC, we talk about this extensively in one of our zines titled Something's in the Air, which we published just a little over a year ago. So I highly recommend reading that and sharing it with others. And just because local risk levels may be lower, that doesn't mean that people don't get sick. People can still get sick, and it may not even be a COVID infection, but it could be another respiratory pathogen that may be circulating. So yeah, masking up is still for me the standard, because every time you mask up, it like every chain of transmission that you break is a life saved, either from an immediate death from an acute COVID infection or slow death via long COVID and organized abandonment. I highly recommend, especially if you are in so-called leftist / radical / revolutionary organizations or communities, to challenge your comrades to take health and disability as a serious site of class struggle. And so this begs the question of like, what is class struggle and why is health and disability a serious site of class struggle? And I fear that this question has definitely already been answered more extensively and more eloquently than what I can do on this panel, but I'm gonna give it my 2 cents. Two texts that I recommend: Class Struggle, A Political and Philosophical History by Domenico Lacerdo, and then Health Communism by Beatrice Adler Bolton and Artie Vierkant. I'm gonna also recommend reading Let Them Eat Plague by Red Clarion. But yeah, like in this world that we're living in, there's the oppressor class, there's the oppressed class. Disability is a serious site of class struggle because health is capital's vulnerability, it's capital's weakness, because without the bourgeois healthcare industry to maintain the health of the labor pool, capital falls apart. Like, even when we cannot work due to disability, capital finds a way to extract profit from us. Like I said earlier, like we get sick, we take up a hospital bed or a bed in a nursing home, and that's profit for the healthcare conglomerates. And then to quote one of ARC-NYC's zines, COVID is not over, the bourgeois ruling class is incentivized to allow mass deaths and disablement because the medical industrial complex is just as capable of extracting profit from our bodies as industry is from our labor. And then to quote Health Communism, health is so policed by capital because health is so necessary to each of capital's functions, and this is why capital only fears health. So yeah, we're fighting a class war in which our enemies don't care if we are well enough to work and make them profit. And so it's in our class interest to keep each other safe and keep each other well by staying masked and implementing all the layered approach we can do. And yeah, it's in our class interest to keep each other safe and well, because this is what it means to be a good neighbor and a good comrade and a good relative to all the living beings that we share the earth with. It's in our interest to keep each other alive and not disabled by long COVID, because when we're disabled, we can't fight for the better world that we're all fighting for. And it only serves our enemies when we weaponize the air against each other and disable each other via COVID and other infections.
Thank you. Really well said. And I think I just wanted to note that people have been sharing links and titles to some of the references that T just mentioned in the chat. I don't know if you want to help add any that folks have missed, T, but Yeah, we can make sure we put those in the recording and write-ups and stuff. As for everything that we're talking about, because I know there have been a lot of references to different data sources and all of that.
Caitlin, I wanted to ask you, T was talking about a little bit about, other viruses that are circulating. What have you been keeping an eye on most recently? And what have been sort of, yeah, some of the developments in other viruses that we've been watching?
We just exited a really nasty flu season and a nasty RSV season. So, although COVID was lower than it has been in past winters, there was plenty of other things going around. Thankfully, we've turned the corner on all three of the big major respiratory pathogens. And so that's a little bit of a respite through spring and often through summer. But it's one of the worst tick-borne tick seasons in many years, actually. And I'll be honest, I'm not an outdoorsy person. I've already found two on me this year. So that goes to show that you have to be alert to the possibility of ticks, even if you're like not really in a tick spot. So there's always something going around for epidemiology and always something to attend to. But thankfully, right now, the big three major pathogens have cooled off a little bit.
Just following up on that, are there data sources that you would recommend for people following tick-borne illnesses?
Yeah, there's a dashboard for everything.
Of
There are
course.
dashboards for tick-borne illness. The metric is not great. It's the percent of people who go to the emergency department. Like this is like the metric, but for tick bites, and a tick bite is not something that you really ever have to go to the emergency department for, unless it's like late and you're developing symptoms. So, anyways, I don't know. I'm not exactly sure what to make of that metrics, but it's an option for you. Many health departments also do their own tick surveillance, where they're sending out entomologists or whatever, collecting ticks from the environment and testing them for pathogens. And those are not like minute by minute updates like we have for respiratory illness, but they're useful for giving you a sense of whether and what tick-borne illnesses are present in your region, which can help you to understand the risk of a tick bite.
That's super interesting. I did not know that there were dashboards for tick-borne illnesses. Yeah, I guess we are going to now just we have about 8 minutes left. We're going to do some questions from the audience. Um, let's see. Is there anything that stood out to you, Betsy, that you want to jump on first?
I know one person was asking about the wastewater metrics from the CDC, so I can try and talk about that real quick. And T and Caitlin also, if there are any questions that you particularly want to answer, please do. But yeah, so the CDC wastewater viral activity level, basically it's one like data from one site historically, com a current most sorry, let me rephrase that. So it's basically like you have one site, you're comparing a recent measurement to measurements from, I believe it's the past year, either the past year or the past 6 months. I'd have to fact check it myself on which it is at the moment. But it's basically like, okay, so currently, say we're at like a 20 out of 100. How is that compared to the last year? Is it on the higher end? Is it on the lower end? And so the CDC analysis process is kind of doing this in like a percentile kind of system where it's like, okay, it's in, higher, lower, medium. Um, and those like comparisons to a historical average then are themselves averaged out. So if you see like a measurement for a particular state, that's kind of compiling from all of the testing sites in the state. And there's a lot of variability here because some states have a lot of testing sites and some states only have a few. A handful just have one or don't have any. And so I think it's always important to check out like what is the kind of overall source of the data, and how comprehensive is it? Like, for example, New York State, where I am, has a really comprehensive wastewater surveillance program with testing in every county, as opposed to, a state like I think West Virginia is one I've been looking at lately, where sometimes it's just one site in the whole state with recent wastewater measurements. So that's kind of an important important factor to check out.
That makes sense. For Caitlin, one question a listener asked is sort of about the current vaccine guidelines for COVID-19. What is currently being recommended? Is it once a year? What are the most current recommendations?
The current recommendations are that we don't do vaccines anymore, so I recommend putting those aside. The previous recommendations before this most recent ACIP committee was once annually for healthy people, twice annually if you have an underlying health condition, especially including an immunocompromising condition that doesn't exclude you from getting vaccinated. So it's either once or twice. If you are forward leaning with your health and wanting to like really adapt the recommendations, I would consider getting vaccinated before the summer wave. Right now, the schedule aligns flu and COVID. So it's the recommendation from the before times is that you would get it like in October, but that's past the summer wave. And so earlier in summer would be a more timely timing, I think. But I'll just throw out one other thing, which is that the composition of the vaccine for both flu and COVID gets updated every year. Ideally, like the purpose of the update is to reflect the variants that are going around, and that is timed for the fall distribution. So if you were to get it in July, just saying it's going to be last year's composition, and it might not be a great match. So there's no clear like, oh, that's the best way to do it because you're really balancing those factors, but just giving some context as you think through what makes sense for you.
That's great. Thank you so much for that helpful overview. I think there's been this administration has caused a lot of chaos, and it's really nice to hear just sort of some some actionable things that people can do if they want to take control of their health. Um, let's see. I think searching through last questions. Um, I think we've answered most of a lot that we can. Does anyone sort of have each panel member just go through and do sort of final thoughts on state of COVID-19, tracking wastewater, any sort of final thoughts to close us out? Do you want to start, Betsy?
I'll try. I'll just say, there's always a lot of uncertainty in infectious disease data in general, COVID data specifically. Um, I find it almost sentimental to think back to like 2020 when there was mass attempts at contact tracing and all of this stuff to really try and like identify and track down everybody who had COVID. And we have gone so far from that. We really are not like yeah, and I think that it's sort of sad, but also really impressive to look back on because that kind of effort was not something that had ever really happened previously. Like if you look at how we collect flu data, it's all based on specific surveillance networks that are meant to be representative of larger communities. So what happened with the kind of early emergency phases of COVID was just like a massive, massive public health undertaking. And the data that we have from that time are like so impressive and so detailed. And yet, even though still have a lot of uncertainty, like I remember back when I volunteered at the COVID tracking project and we were closely following state dashboards, and some state dashboards had a metric that was like recovered from COVID, which was kind of based on like taking numbers of people who were hospitalized and then like subtracting the numbers of people who had died and assuming that everyone else was fine. It was like a very odd thing, but of course now we know that long COVID exists and that many people who first got infected during that time in 2020 still have symptoms. So I think that there's both a lot a lot of impressive work that has happened with public health over the last few years with the surveillance of COVID, and a lot that we can learn, and still a lot that could be improved for the next big outbreak and for obviously continued COVID tracking as it goes on. Um, Sorry, I feel like that was maybe not the most coherent answer, but I don't know. I care a lot about this stuff, and I'm glad to talk to other people who care and have smart questions.
No, that was great. T, any final thoughts?
Sorry, what did you say?
I just said any final thoughts about COVID-19, COVID-19 safety, sort of anything you'd like to end with?
Um, Mask up, read, keep each other safe. Yeah, that's all I got.
That's great. And Caitlin, we'll close with you. Any final thoughts?
I'll use a prompt that Anna offered in the chat, which is what's our like the leverage point for for agency about like promoting better data collection, or really, I'll expand it to say anything related to public health. The CDC and the federal level is actually not where the power lies in public health. It's the state and local level. That's where all the legal authorities are. That's where the data is collected and reported. And that's where laws or regulations or other enforceable policy is made about things like masking and all of the restrictions that came out on and off during the pandemic. Those are all state or local actions. And so that is where I would suggest that you focus your attention and your energies, because that is where the change would come from.
Thank you so much. Please, a round of applause for all of our guests, for Betsy, for T, for Caitlin. Thank you all so much for joining us tonight and sharing your wisdom with us.
Thank you.
Thank
Yeah, thanks
you.
everyone for
Yay.
coming. Good look out for the recording and other stuff to be shared in the next few days.